and gentlemen, and a warm welcome from a wonderful Cape Town. You must realize that it's very busy outside. Steve, are you going to do the Argus on Sunday?
No.
You're not?
This year, and you?
No, I'm not that sort of person, Steve. So I'd like to firstly start by welcoming our speaker, Dr. Judith Carter, who's in fact a specialist obstetrician and gynecologist from Netcare Park Lane Hospital, and that's in Parktown in Johannesburg. And Judith is going to be speaking about an update on the use of GLPs in the management of obesity in women. And as you know, this is a huge problem. A third of people over the age of 20 in the developed world are obese, Steve. Well, that's accepting you, but it does include me. And for that reason, it's a very, very important topic. It's sponsored by Novo Nordisk, and we're going to have Eamon at the end of it saying a very, very quick thank you to Dr. Carter afterwards. Next week, we have, in fact, the professor himself, Professor Stephen Jeffrey, speaking about overactive bladder, and that is sponsored by Astellas. Don't forget, on the 25th of March, Steve, we have a Pelvic Floor Foundation workshop, and that's essentials in stress urinary incontinence. So if you want to register for the 25th of March, it's face-to-face, it's not hybrid. We would love to have you over there. It's held here at the Chris Barnard Memorial Hospital, and it's going to be practical sessions. In between times, the presentations are going to be live.
Yeah, so just as a quick punt for that workshop, it's a live surgery intermingled with some lectures, and it's really going to be excellent for registrars, anyone who's doing exams. I think we'll be covering a lot of stuff that might actually come up in any urology or gynecology postgraduate exams. So come for that. It's registration to the registrar is like 700 rand, I think, or something. So it'll be great to have anyone for that.
Of course, free teas and coffees and as much food as you can eat.
Yeah, good. So, without further ado, Pete, you want to
we look forward then this afternoon, ladies and gentlemen. Firstly, a great big thank you to Ash, who's set this up. Ash is our resident technician. So we're looking forward to an update on the use of there's Ash, an update on the use of GLPs in the management of obesity in the female woman. Dr. Judith Carter.
Hello there. Thank you so much for the invitation to speak. Let me just quickly sort myself out here and share my screen. There we go. Okay. Can everybody see?
We can. Yes. Thank you very much.
Managing. Wonderful. Okay. So I'm going to give you quite a broad overview before we go straight into discussing the GLP-1 receptor agonists. I just want to make sure that everybody understands that the views that I'm expressing are my own and not Novo Nordisk's. And I do have a few declarations, and I'm hoping with time that list will get even longer. That's a small hint to anybody who's listening. So make no mistake that weight issues are a huge problem for everybody, but particularly for women. I mean, I treat mostly an older population group, mostly menopausal women, and there is not a single woman who doesn't sit down in front of me and complain about her weight. So it really, really is a big issue in gynecology. We know for sure that it's a global pandemic. 650 million people are living with obesity. And of those, probably less than 40% are actually diagnosed with obesity, and less than 20% are receiving any kind of treatment. In South Africa, 35% of our adult population are living with obesity, and 23% of adolescents are living with overweight or obesity. So it really is a huge problem. So let's look very briefly at what the factors are that influence this positive energy balance that we have seen over the last few decades. And it really is very multifactorial, and it's got to do with the kinds of the lifestyles that we are leading these days that promote overeating and discourage energy expenditure. We're leading a very sedentary lifestyle these days, and a lot of our work gets done around a table. And of course, the pressures of modern life can lead to overeating or eating for comfort. Let's make a very important distinction here, though, between the metabolically healthy patient with obesity and the metabolically unhealthy patient with obesity. The metabolically healthy patient has got increased adiposity, but no metabolic syndrome, no increased in intra-abdominal white adipose tissue, with fairly stable adipokines. And those patients do not have an increased risk of type 2 diabetes or cardiovascular risk at that point in time. Whereas the metabolically unhealthy patient has got exactly the opposite. There's systemic inflammation, there's metabolic syndrome, they've got increased fat around their organs, which is highly metabolically active, and all of the adipokines are favoring an increase in type 2 diabetes and cardiovascular risk. But unfortunately, we can't feel comforted if we are metabolically healthy living with obesity, because unfortunately it's a transitional state. And most women who are metabolically healthy initially will move on to being metabolically unhealthy by the time they're 60. I don't need to tell you, having many gynecologists, if not mostly gynecologists in the audience, that obesity has a huge impact on obstetric and gynecological care, all the way from the kind of contraceptive we would choose for them to the kind of hormone replacement therapy we would choose for them. For example, we know that oral contraceptive pills and patches are less effective in the patient living with obesity. And certainly from an HRT point of view, we're trying to avoid the oral agents to not increase thrombosis risk. In terms of general gynecology, there's a huge association between PCOS and obesity, leading to amenorrhea and decreased ovulation, infertility. Women who struggle with their weight are much more at risk of mood disorders. And of course, there's the cancer risk that goes up. From both endometrial and breast cancer are a significant problem in the patient with obesity. In pregnancy, there are huge risks associated with obesity, not just an uncomfortable pregnancy, but also diabetes, hypertension, preeclampsia. The labors are more difficult, with more risk of maternal injury, increased risk of cesarean section, postpartum hemorrhage, and of course, thrombosis is a risk. The baby also is not immune. There's a higher risk of spina bifida. Big babies can lead to difficult deliveries with shoulder dystocia and brachial plexus injuries, fractures of the clavicle, and this certainly increases perinatal mortality. So it really, for us that work in the obs and gynae sphere, overweight and obesity is a huge issue, and we need to be prepared to address it. So what are the beneficial effects of body weight reduction in women? Well, we've got all the general effects, obviously lower blood pressure and improved lipid profile, improved control of sugars via increased insulin sensitivity. Type 2 diabetes can be almost completely reversed with a 15% weight loss or more. Lower cardiovascular risk, improved comfort in your body. You sleep better, your joints work better, your liver works better, so less non-alcoholic fatty liver disease. Specifically from a gynecological point of view, the PCOS symptoms improve, meaning the patient has got less acne and hairiness, they ovulate, their fertility improves. So that's very important. And for this particular audience, weight loss also helps with stress incontinence and decreases the risk, or certainly the deterioration, of pelvic organ prolapse. and once again, a lower risk of those cancers that are so important. So how do we classify overweight and obesity? You'll notice I'm very careful with the language that I use. We shouldn't be talking about obese patients or overweight patients anymore. Try not to label these patients. They feel bad enough about themselves anyway, without us coming with language that labels them and makes them feel worse. So there's very much a trend towards talking about people who are living with overweight and obesity, or people who have overweight and obesity. In terms of the body mass index criteria, it's not the best measure. Well, it's the best measure we have, but BMI does have some, yes.
Sorry, Judith.
Yeah.
Can you just clarify that point? I mean, as you say, it's something that is extremely important, being correct here, the way we label them. I mean, I don't know if you've heard about Roald Dahl's children's books where they're called, the one chap was excessively fat, and they said, no, he's not excessively fat, he's just excessive. So what should we call, what
they're rewriting the books now.
They're rewriting the books because we don't like the word fat.
Yeah.
What actually is the correct term applied to people that are excessively fat?
So when we talk about patients living with overweight or obesity. So we say, we refer to the patient as somebody who is struggling with overweight or obesity. So rather a descriptor than a label. And as a matter of fact, we've done away with terms such as morbid obesity or you are morbidly obese. We rather say, if you've got a BMI above 40, you have class 3 obesity, or you struggle with severe obesity. You're living with severe obesity. So it takes quite a mindset shift. And it takes a little bit of practice, but eventually it becomes easier to speak about it in those terms. But I do think it's quite important.
Yeah.
Then just in terms of looking at the BMI classifications and who benefits from what in the managing obesity space, obviously everybody, no matter what their BMI, is going to benefit from looking at their diet, following a good eating pattern and regular physical activity. So that's where we're talking about, just a lifestyle. But then comes behavioral modification. So for example, I love to put a slide up of a young mom who's got tears saying, I don't understand why I'm gaining weight, but she's drinking half a bottle of wine to get through suicide hour with the little kids. That sort of thing contributes to this weight gain, and you don't even realize it. So one needs to look at one's behaviors and modify those. Then in terms of pharmacotherapy, that very much is for the patients with a BMI of 30 or over, they don't even have to have a comorbidity for that. But anyone with a BMI of 27, between 27 and 30, if they've got adiposity-related complications or comorbidities, they can benefit from pharmacotherapy. When it comes to surgery, which is probably the most effective tool for weight loss, when you look at the BMI category of between 30 and 34.9, if the medical measures and behavioral changes have not worked, you may have to look at surgery. And certainly anybody with a BMI over 35 who has got comorbidities may want to move straight onto bariatric surgery. I don't know, for me, I think there may be room in even considering pharmacotherapy for those patients. So how do we approach drug therapy? Well, we've got to look at what our goals are. Our goals are to reduce weight and to maintain that weight loss, and so doing, hopefully improve their health status at the same time that we're minimizing adverse effects. When we look at reducing weight loss medications can assist with anywhere between a 5 to 22.5% weight loss when you combine that with a lifestyle adjustment. And different individuals are different. Some medicines work for some people and other medicines will work for others. And sometimes you have to try a few before you know what works for them. It's so, so important that we as healthcare practitioners and as patients understand that it's normal for that weight loss on pharmacotherapy to plateau. And this may not be at a BMI of 21 to 25. So we have to make sure our patients have got realistic expectations of the treatments that we are offering them. Sadly, also with discontinuation of the medication, the weight loss or the weight regain is very, very, very common. And that's because, you know, human beings are very, very well adapted to conserve energy and to store energy, because our hindbrain is still living in the caveman times when we were only getting a meal once a week. So our body adapts by decreasing our energy expenditure and changing our appetite mediators to preserve that, you know, to try and get back to that highest set point of weight that we achieved, unfortunately. So treatment therefore really may need to be long-term. So when we look at how weight loss improves health status, we know that loss of 5 to 10% significantly decreases cardiovascular risk factors. 15% and over may cause diabetes to disappear completely. We do, though, expect a minimum loss of 5% by about 4 to 6 months of treatment. And in general, the patient should feel better. Their body should move better. They should have less pain. Their comorbidity measures should improve. And most of these patients are much, much happier to have lost even just a little bit of weight. It's very important that we counsel patients about how to adapt healthy eating patterns and physical activities. It's important for us to assess for comorbidities and decide who needs drug therapy, and then we go on to choosing an agent. I've put this slide in right at the last minute because I think it highlights something very important that I want to talk about, and that is that when we approach these patients, we need to ask them permission. We need to ask them whether it is okay for us to discuss their weight, because it shows that you're compassionate and that you're empathetic, and it gives them the opportunity to actually say, no, I don't want to discuss my weight at this juncture, and that's okay. Maybe they will come around with time. If they see you a couple of times, they may feel more comfortable with you to actually broach the topic. Let them guide you on that. I think that's very, very important. How do you assess for comorbidities? Well, in your clinical exam, obviously you're going to do a blood pressure, so you'll know what their blood pressure's like. I like to do a few blood tests looking at the fasting glucose. I may do an HbA1c. I'll look for insulin resistance. I'll do a fasting lipogram. I may even do a highly sensitive CRP. I always do the transaminases because those are often raised. And I ask them questions about whether they struggle with issues around sleep. Many of them will have musculoskeletal issues and will find it difficult to move around, and that will be important as well. The candidates for drug therapy are those who haven't met appropriate weight loss goals. And by that, I mean at least 5% of their total body weight in 3 to 6 months with the lifestyle measures, diet and exercise that we've talked about. Patients who are over 30 kilograms per meter squared can move straight onto drug therapy, and anybody 27 to 29.9 kilograms per meter squared with weight-related comorbidities can move on to drug therapy. Let's have a look at what the drug therapies are that we can offer. I'm going to go very briefly through the enteral therapies or oral therapies. Yeah.
Before we go on to that, can I just ask you something? So there's so many diets on the market and so many things that we can offer patients. I mean, there's intermittent fasting now, which is becoming quite popular. You've got the old banting and keto. Yes. Is there something that you prefer to start with? I mean, they all work differently for different patients, and some must pick what they want. What is your sort of favorite to start with?
So if you look at the data, there's really only one diet that has excellent data, and that's the Mediterranean diet. There isn't really very good data on intermittent fasting. There isn't great data on banting and that sort of thing. But then again, I'm sure you've had lots of patients who've done very well with intermittent fasting, with banting. But the data is really around the Mediterranean diet. So minimizing the intake of red meat, even minimizing chicken, rather going towards fish. Your complex carbs are going to be your whole grains. Your healthy fats are going to be olive oil and olives, and then lots of green leafy vegetables and fruit, but not too much fruit, because fruit is highly calorific. But that's really what I usually advise patients. So if they've got a diet that has worked for them in the past, sometimes they maybe need to go back to that.
Well, many years ago, Zane Stevens told us that a calorie is a calorie is a calorie. Would you hold with that? And secondly, he made the controversial thing that if you're going to go to the gym and work out like Steve does over here 3 times a week, all you're doing is changing your fat to muscle. So you're not going to lose weight by going to the gym. You're just going to have a better body and change your body fat composition. Would you agree with those 2 statements?
So the data very clearly shows that exercise does not help you lose weight.
Yeah.
Okay,
yeah.
Not at all. But so exercise definitely does help you to maintain the weight you're at, which is important because the biggest risk factor for weight gain is aging. So exercise is very important to try and maintain weight. And also certainly for menopausal women, not so much cardio as you would think. Weight training is very important, or strength training, because yes, exercise does change that ratio, but muscle is metabolically far more active than fat is. And that's one of the theories around why we gain weight as we get older. It's because of sarcopenia.
Sarcopenia?
Sarcopenia, yes.
Muscle atrophy.
Yeah, so when your muscles naturally atrophy as you age. So I think if you fighting against that by doing strength training, surely that can only help. But we've got to enforce that patients they need to modify their diet if they want to lose weight, and to lose belly fat is mostly diet.
Really? So that if you've got a bit of a belly like me, the best thing to do is to eat less food.
Well, yeah, perhaps, but this is where this this whole field of medicine is so exciting, is because I think the days of us saying that it's a calories in, calories out kind of scenario, that landscape is completely changing, because we're realizing now that weight management has got a lot to do with the brain and the brain-gut axis and how that interacts. And that there are certain individuals that unfortunately are always going to be on the track that is storage versus on the track that is burning of calories. And that's why you will have patients that will say, I'm doing everything right, I'm eating properly, I'm exercising 7 days a week, and I still can't lose weight. Sadly, load shedding. Sadly, those patients are always going to be at a disadvantage, and that's where these medicines are coming in and hopefully going to revolutionize things for us.
Thanks so much.
Oh, thanks. It's
Okay.
very field. I think it's a very topical. It's very dynamic. I think new things are coming out all the time. So yeah.
Absolutely. So let's just look quickly at the enteral therapies. So there's phentermine. What we've got in South Africa is phentermine, bupropion, naltrexone, and orlistat. Those are our oral agents, and the only parenteral agent that's registered for weight loss in our country is liraglutide. Let's have a look at what's going to help us to choose. So believe it or not, all of these agents help patients lose weight. But the problem is we don't have any head-to-head trials saying which one's better than the other. And we also don't know what to offer patients who have failed on one particular drug therapy. So it's very much going to be dependent on what their comorbidities are, what their contraindications are, what you're going to give them, what their preference is, and also what they can afford, because these new drugs are not cheap. In terms of the oral agents, phentermine is very old-fashioned and it is a sympathomimetic. It mimics amphetamine. So we need to be careful. There's strong abuse potential there, lots of side effects, and it's contraindicated in many circumstances. Bupropion.
Yeah. Can I just ask, Judith, which one is that? The Duramine?
That's
what is Duramine? Duramine, okay. Because every day one says, can you prescribe Duramine? And I have no idea what they're talking about.
So Duramine is phentermine, and yeah, it's what we had, but it's not great, to be honest. Then we've also got bupropion naltrexone. That's recently been released in South Africa. It's called Contrave. It's built up slowly over 4 weeks. And it's also got a fair amount of side effects, and obviously patients who have got psychiatric comorbidities can be at risk of suicidal ideation with this drug. So you've got to just be a little bit careful with this drug. And as a matter of fact, in the US, they actually prefer a combination of phentermine and topiramate to bupropion naltrexone. And then good old-fashioned orlistat, which is a pancreatic lipase inhibitor that you take with your fat-containing meals, causes lots and lots of really gross side effects like flatulence and cramps, makes you very unpopular when you're leaking fecally and all sorts of oily stuff coming out your bum. And besides that, you malabsorb the vitamins that need fat for absorption.
How would you persuade a woman to use oily whip when it's going to cause her to soil her pants with oil? I mean,
well, exactly. Exactly. The only way you're going to convince a woman to do that, and truthfully, this is what the endocrinologist had been recommending up until quite recently. It's because that's what there was, you know, but also it's pretty cheap in comparison to the other stuff.
Yeah.
So let's have a look at our parenteral agents. So these are GLP-1 receptor agonists. Liraglutide is a daily subcutaneous injection, and it's the only agent that is registered for obesity management in South Africa. In terms of how do these drugs work? Well, we've got to know a little bit about how food intake is regulated. So there's a whole lot of chemicals or substances that our body produces in various parts of our body that affect how our body regulates food intake and how it deals with what we've eaten. So something like ghrelin, for example, is orexigenic, so it increases appetite. Whereas something like leptin is anorexigenic, so it creates a sensation of satiety. And this is where the glucagon-like peptide 1 comes in, because it creates that sensation of satiety. This is quite a busy slide that I've put up mostly because I want to enforce that these agents or these substances that are released by the gut communicate directly with the hypothalamus through the arcuate nucleus and the paraventricular nucleus. And if you look at the left side of this diagram, those are the folks who are going to struggle with weight loss, even though they're doing everything right. Whereas the folks that are on it would be my left and the right side of this picture, those are the folks who can eat whatever they like and they never gain weight. So we need to understand that people who really are trying their best they're not ill-disciplined, which I think is a societal thing that we all have. Oh, a patient that's got obesity must be ill-disciplined and eats whatever they want, and that's not always true. So we've got to look at also how our appetite is regulated in terms of homeostasis and hedonism. So homeostatic regulation talks to that need our body has to be fed, and it changes it's dependent on our energy expenditure. But hedonic regulation is where one gets pleasure through eating. And this can operate even when we're full. It can make us eat more even when we've had enough, and also can make us eat the wrong things. So homeostatic eating, to recap, is eating for hunger, but hedonic eating is eating for pleasure. And then there comes the prefrontal cortex, our executive function, which makes us decide when to eat and what to eat. So the role of GLP-1s in appetite control and energy intake is really where the crux of this discussion is. It's secreted predominantly in the L cells in the gut, but it also comes from the brain, and it's released in response to food intake. It increases that sense of satiety and it reduces hunger significantly. When we look at where the receptors are for GLP-1, obviously there are those in the gut and in the hindbrain, but look at all of these different organ systems of the body that have got this receptor. And therefore there are beneficial effects to be had throughout the body. So what is liraglutide? Well, it's a once daily subcutaneous injection of an analog of human GLP-1. It's 98% homologous, so it's almost bioidentical. It's got a long half-life of 13 hours. It stimulates those anorexigenic neurons and it inhibits the orexigenic neurons in the hypothalamus. So it increases satiety, it reduces hunger, and therefore hopefully reduces your energy intake. It also reduces brain activity related to the highly desirable food cues. And if you look at the studies that have been done in animal models, specifically mice models, these mice definitely move away from eating the candy more towards the healthy food, the chow food, the chow group. So one hopes that your food choices will be better as well. GLP-1 receptor agonists have got multifactorial effects. So if we look in the brain, obviously it helps you to lower your weight by having less food intake from greater satiety. There is a slower gastric emptying, which means you feel full for longer. And it has a whole lot of good benefits in terms of sugar control, glucose control in the pancreas. In the heart, it decreases your cardiovascular risk. There's improved fatty acid metabolism, lower blood pressure and lower inflammation. And then in the liver, there's a lot less steatosis, there's less endogenous glucose production, more insulin sensitivity, and less fat production. So how do we initiate these medications? Well, once you've done your due diligence and you've done your basics, you've worked out the BMI, you've worked out what the comorbidities are, you've decided that this is the drug for the patient. It's a subcutaneous injection that you can administer in the thigh, the upper arm, or the abdomen. You start in week 1 at 0.6 milligrams, and they use that daily. In week 2, they go to 1.2 milligrams, week 3, 1.8, week 4, 2.4, and then from week 5 onward, ideally you want them on 3 milligrams subcutaneous daily. It's important to monitor their progress. Are they losing weight? What's happening with their blood pressure and their heart rate? You know, these are guidelines that come from up to date, but I guess it can be you know, you need to look at how you would work it in your practice, but I think one does need to do a checkup for these patients regularly. If you find that the patient is struggling with a lot of side effects, you may want to maintain that dose that they're on for an additional week, because often the side effects will improve with a little bit more time on that dose. And ideally, they must lose, yes.
Can I just ask Amanda, Judith, the side effects, apart from poverty, what other side effects can you expect?
So we're coming to that. I'll get there. Next slide. So we want them to lose 5% of their body weight on their maximum tolerated dosage after 12 weeks of therapy. If they don't do this, then you should discuss with the patient whether you should wean this drug. I have a feeling that if the weight loss is 2.5%, they might feel that they'd want to continue it if money is not a problem. But I think the discussion needs to be had that ideally it should be 5% weight loss. The patients who don't respond may want to try another medication, and you can combine some of these medications. So glucophage is often used with other medications. And while we don't have data beyond 3 years, it really does seem that these patients do need some sort of continuous therapy, certainly for a year. And there may need to be some sort of bespoke regimen that they need to be on in the long term because of that inevitable weight gain that happens when the drug's stopped. So let's look at the side effects and contraindications. Well, this is a very safe drug, mostly because it works mostly at the level of the gut. It can cause those side effects of nausea, vomiting, and diarrhea. Patients who are diabetic and are on other agents, you need to be a little bit more cautious that they can become hypoglycemic, and their diabetic medicines may need to be adjusted as the weight loss ensues. We need to just be cautious about the less common but far more serious side effects or problems of pancreatitis and gallbladder disease. Renal impairment can also be an issue. And that's why we don't give these medications to patients who've got a recurrent history of pancreatitis. If they've had one episode of pancreatitis due to gallstones and that's been managed, there is a discussion point around perhaps they can use the drug, but we need to just be careful. And then, of course, there is a warning about medullary thyroid cancer, and this is because rodent studies have shown an increase in both benign and malignant tumors, but human studies haven't managed to reproduce that, and that's probably because the thyroid, a human thyroid, is very different to a mouse thyroid. We have fewer C cells and we have fewer GLP-1 receptors on those C cells. So for now, it doesn't seem like there is a huge issue with thyroid cancers, but we probably wouldn't put patients with a history of family history of thyroid cancer on these drugs. It's very important also to know that when you use Saxenda, Novo has certainly gone out of their way to create a care support program. And what you're seeing here is a page that it's a tear-off page that we get from you know what I mean, those tear-off sheets that we fill in for the patient, we sign, we get the patient to sign, and that is how they enter the support program. I then have contact with a dietitian that is works with Novo, and I get my patients to go straight to her, and what she does is she gets them enrolled on the program, she shows them how to inject, she monitors their weight and their body fat percentage and how that changes over time. And very important to know that 2 hours of her time is paid for by Novo Nordisk. So she can have an hour-long session and then another hour-long session at another time, or she can even split that up into half-an-hour sessions to make it last longer. But this really is very, very important for the patients to be aware of.
So Judith, is that available in Joburg, Cape Town? How do we actually get access to that specific dietitian?
So I'm sure that your local representative, it should be available, I would say, throughout the country, isn't it? And the way to access it would be to speak to your local Novo Nordisk rep, who will be able to put you into contact with the people involved.
Excellent.
I just wanted to show you the tools that I've received and that we use. There is a pen that I use to show my patients how they inject. There's also a lovely little kit that the patients get where, you know, this is a very, very useful booklet telling patients how to get started on this drug, and also a very, very nice meal plan guide. This is a slide that I've just put in, so I'm not 100% familiar with it, but this is something called Truth About Weight, right? It's a digital disease awareness platform. You can get onto it as a member of the general public. It's got lots and lots of information about living with obesity and how to manage this. There's a virtual coaching platform, which is apparently free, 40 weeks long. And this is something I even need to investigate, because I don't know a hell of a lot about this, but it seems like you can register with a box barcode and create a profile. I'm sure Novo can speak more to this as well. And then, of course, telecoaching with obesity patient educators is a telephonic support program, and it helps patients in this journey. I think it's very, very important. And I want to thank you so much for your attention. I don't feel like I'm an expert in this field, but I'm learning. And I think from a gynecological point of view, I see great scope for this. I really, really do.
Thank you very much. It's been wonderful hearing from you. There are some questions. Steve, could you just go to the first question there and then just...
Oh yeah, there's one question, yeah. Can drugs like Saxenda be used when breastfeeding?
Probably not.
No, there's no data. I doubt there's any data in pregnancy and breastfeeding, so we don't recommend that these are used for patients who are trying to fall pregnant or who are pregnant and breastfeeding. But I would say there is a big role to play in the patient who is planning a pregnancy, who's still on a contraceptive. I get lots of patients like that who are planning a pregnancy maybe next year. And as part of my counseling and my pre-pregnancy blood screen, this is something up for discussion in the patient who's struggling with obesity. Because if she can lose even just 8 to 10 kilograms, that can make a huge difference to her obstetric outcome.
Thank you very much. Here's another question from Habib of Nairobi. What is the place of intragastric balloons in the management of weight loss? Do you have any experience?
I have absolutely no experience, and I wouldn't claim to be any expert on that, to be honest. I really can't comment.
So you'd have to speak to, find an expert on that subject.
The bariatric surgeons. From the little bit of research that I've done for other talks, it's not something that has been put forward as preferable. Usually the bariatric surgeons are going to do the standard Roux-en-Y procedure or the sleeve gastrectomy. Those are the two procedures that are done most commonly in South Africa. I really didn't find any information on the balloon, and I'm not so sure about its veracity.
Another question, can the bariatric surgery options be done laparoscopically?
Definitely. I think it's uniformly done laparoscopically these days, if I'm not mistaken. Yeah. Certainly any of the surgeons that are doing it a lot in Joburg are doing it laparoscopically.
Now, I asked because I had a patient this week, in fact, who seemed to have lost 45 kilograms just by adhering to a diet and better eating options, until I examined her and I found tiny little laparoscopic marks on her abdomen. And I think she'd had bariatric surgery that she was keeping a secret. So that is interesting. So it doesn't show. Steve?
Yeah, well, I mean, I think the bariatric surgery has proven to be very successful. A lot of my patients. In fact, one of my patients went to Turkey, of all places, and had it done very cheaply, very recently.
Really?
Yeah, and I mean, I think she said she's been 47,000 rand for the whole trip. So well, so I mean, but it's anyway. But I mean, there are great guys in Cape Town and in Joburg doing laparoscopic bariatric surgery. They all follow a program. They've got endocrinologists, they've got psychologists, and I mean, obviously, it would need to be in a very well-structured program.
It's just part of the options of weight loss.
Something that I'm quite interested in is just the whole probiotics and microbiome and diversity of diet. I mean, I think that's kind of completely underestimated, and I think that's probably the place that we're going to be looking at next as well. Are there any comments about that, Judith?
I don't know a hell of a lot about that, to be honest. But when we talk about that gut-brain axis, it's not just about the hormones and the substances produced by the gut, how they interact with the brain, but it's also got to do with the microbiota. But I must say, I need to do a lot more reading on that. You probably know more about it than I do.
And then there's also, there's all fecal transplants. I mean, that could potentially be something that we might be looking at one day as well. And
but for mass loss, Steve?
Well, I mean, the microbiome and looking at that, and exactly what Judith is saying, the gut-brain axis could be interacting at that level. very closely. I mean, certainly, I mean, for recurrent UTIs, we're looking at a lot of that for, you know, in the microbiome and replacing it with probiotics.
And for vaginal discharge.
Yeah.
Judith, do you have any experience at all? Tell me if you don't, on women that are under 40 kilograms that wish to gain weight, but they try everything and it seems as difficult to gain weight as to lose weight. Do you have any comment on that? Maybe an anti-GLP agent that has the opposite effect, maybe? Stimulates.
If only we all had that problem, but no, I can't really comment too much about that. I do worry a little bit about how honest and truthful these patients are being. I've definitely had patients who have discussed with me away from family members, etc., that as a matter of fact, they are binging and purging and that sort of thing. So I'd always just be very careful. And of course, in the older patient, we need to be cautious about, you know, losing weight for no reason. Hopefully they don't have a malignancy or something like that that needs to be worked up.
Okay.
There are actually a number of other questions that we need to ask. Again, from Rindani Maboko, how do patients maintain weight loss after using Saxenda? I think you did mention that.
Yes.
Exercise. We said
Well,
exercise.
look, I think to be honest, maintaining that excellent diet and exercise doesn't work for a lot of patients. So I think because we don't have data yet, every patient may need to, you know, when it's been a year, come off the medication and see what happens if they maintain that healthy lifestyle. But if they gain weight, we don't yet know, is there going to be a way that these patients can move forward using the drug, but perhaps not having to use it every day? I mean, are they going to use it on the weekend? Are they going to use it for a week, once or twice a month? We don't really know. And I guess that's where a lot of the investigation is going to be focused on, because we know it works. And we know that patients gain weight when they stop it. So what we now need to figure out is how we're going to manage them in the longer term. And there's going to, I'm sure, be a lot of exciting information about that in the next couple of years.
Thank you.
Premila Naidu wants to know, firstly, she says, great talk. Is there any place for stopping the drug preoperatively, and then how soon to start it afterwards?
Preoperatively, that means pre-bariatric surgery operatively.
I don't know, but I mean, is there any perioperative issue? Can you just carry on through your, if patients going for operation, maybe for something? I mean, maybe a prolapse or maybe a prostatectomy or something?
Judith?
I must say, I don't know the answer to that question, but I would imagine that you need to be a little bit cautious, because if they're having an operation, well, there we go. We've got Nova's going to contribute. Tell us, what's the answer?
Thank you so much, Dr. Carter. I mean, we have some data regarding the bariatric surgery use of the Saxenda. And actually, I mean, it is also, there is a benefit to use the Saxenda pre-bariatric surgery, because the patient, they are going to lose weight, right? They will also decrease the liver volume, which also affect in a good way, will affect the outcome of the surgery. And the recommendation, of course, if the patient go under bariatric surgery, they don't need to continue for a medication just after the bariatric surgery, because the reason of the bariatric surgery for them to lose weight. But also we have data and shows that for a patient who doesn't lose enough weight loss with bariatric surgery, or for patient who start to regain after the bariatric surgery, generally around 1 or 2 years, they start to regain, and they have data that shows the efficacy and the safety of the Saxenda for that patient. They continue to lose weight. They stop regaining, and they also, there's a benefit to use the liraglutide 3 milligram in terms of the losing more weight. That's what I can say. Of course, when patient,
do you continue it? Do you
yes,
continue it right up to the surgery?
Just after the surgery, it doesn't make sense actually to continue to Saxenda, because the reason of the bariatric surgery, actually, it is a very big invasive method. So, right, there are also complications of the, the surgery itself. So for, we don't recommend directly start Saxenda just after the surgery. The patient, they need to be observed. And then depends on the weight loss situation. And there is no limitation, just 2 or 3 months after the surgery, the patient, they can use the Saxenda. There is no limitation. But here that the patient's status is going to be important to make decision when to start liraglutide 3 milligram.
Thank you very much. Another question from Vinci Molekewa. Does Saxenda have teratogenic effects? Yes or no, Judith?
I have no idea if there's data on that, to be honest, but you know, it definitely should be avoided in pregnancy. I don't know, you know, what do you say? What do you think?
I'd say that there is no data, but you shouldn't use it anyway. And then Graham Bertie says Saxenda is often out of stock. Can you say anything about Victorza and Ozempic? Is that the Orlewip stuff? Pharmacists often give patients this as an alternative. Okay. Can you comment?
Yes, I can. So Saxenda and Victoza are the same agent, right? Liraglutide. But Victoza is, you get to 1.8 milligrams, whereas with Saxenda, you're getting to 3 milligrams. So obviously, from a weight loss point of view, the benefit's going to be much greater with Saxenda than with Victoza. In terms of Ozempic, Ozempic is not registered for weight loss in South Africa, not at all. And the other issue with it is that it is meant for diabetics. So unfortunately, the indiscriminate prescription of Ozempic, which is semaglutide, has led to many diabetics and those with fatty liver disease not getting the drug they need. And besides that, it's not cheaper at the dosages you need for weight loss. And, you know, the only benefit, patients think that because it's a once weekly injection, it must be better, but it actually isn't. Saxenda is the drug of choice currently in our country for weight loss.
Thank you. Steve?
Great.
Laura Graves has got a question.
Laura Graves just really wants to know, thanks, Laura, for the question. For those women mildly overweight, wanting to lose about 10 kgs or less in order to reach their personal goals, is the use of liraglutide acceptable? And she says she has a huge demand in her practice for these types of patients who want to use it a little bit, I need a little bit of weight. Or I think 10 kgs is actually quite a lot.
Oh, we are.
Yeah, it sounds like that's what it's for.
So that would be off-label use, because it's very clear that you need to have those BMI criteria. So if you're going to prescribe this drug properly, we should know what the patient's BMI is. If it's 30 or over, they can use liraglutide without any comorbidities. But between 27 and 29.9, if they want to use it, there should be some comorbidity to justify its use. Anybody using it under 27 for weight loss is using it off-label.
Great.
Thanks very
And
much.
of course, it's going to work, but I mean, it's off-label use. You don't really have a leg to stand on if that patient gets a pancreatitis. And you know, have they put in adequate lifestyle adjustments to lose that weight? You know, I think we know that patients who are on these medicines, many patients, if they use this medicine as a panacea and they don't actually make the lifestyle adjustments, may not lose weight at all. So it all goes hand in hand. They need to be serious about making lifestyle change to earn the drug, in my opinion.
Okay. That's good. Thank you so much. So it's
One
been wonderful.
One quick question I've got over here. Do you know anything about the effect of vegan diets? Is that an intrinsically more healthy diet than the usual diet that a Western person would follow? In other words, would you lose weight more successfully if you were on a vegan diet?
So I'm talking now as a healthcare practitioner and a person who's looked into diet. Veganism, I think you've got to be very careful. You've got to really do your research if you follow a vegan diet, to make sure that you aren't deprived of very important nutrients. Protein intake has to be prioritized, and iron deficiencies are very common. B12 deficiencies can happen. So I don't think you can follow a vegan diet willy-nilly and say that you are going to be healthier than the individual who is following a Mediterranean diet, for example. We do need protein, and it doesn't have to be from animal sources, but obviously animal protein is the obvious source. So you really need to work out your meal plan very well to make sure that you aren't deficient in your macro and micronutrients.
Is your feeling that vegan people are healthier and less obese than non-vegans?
Not necessarily, because I think they may be healthier in some respects, but they also may be less healthy in others. In speaking about the deficiencies that we've discussed, but also in veganism, in order to make that food palatable, you can often end up taking in large amounts of calories to make that kind of eating palatable. And also, what do is we go and, instead of just focusing on fruit and vegetables and complex carbs, we go and buy all these meat replacements. And those can be highly calorific. So my feeling on veganism is that if you're going to follow that kind of diet, you shouldn't be replacing meat. Certainly not on a regular basis. Maybe for a special occasion, you can go and get yourself a Beyond Burger or something like that. But your focus actually needs to be on eating fruit, vegetables, and complex carbs, and to find happiness in eating that way, to modify your lifestyle, to eating to live rather than living to eat.
Thank you. Thank you.
Great,
Steve,
great.
are you going to thank?
Yes, so
Thank
thanks
Judith.
so much, Jude. That was fantastic. I mean, you brought up so many questions, but also provide lots of answers for us, and given us some good guidelines in terms of how to use, some of these newer drugs. And I think they are being used, and we've got a much better idea of how to prescribe them. So thanks so much, and thanks for your time.
Absolute pleasure. I really enjoyed it. I'll come back anytime.
Okay, we'll have you back. Yeah.
Be careful what you promise.
Yeah. We're going to move on to Ermin. Dr. Ermin Yerogu.
Yeah.
And we'd love to hear something, or you just going to be speaking.
Perfect. Thank you so much. First of all, thank you so much, Dr. Carter, for an excellent presentation. I think you clearly mentioned and state all of the importance, the area regarding the therapy, pharmacotherapy and management, but also obesity. And I also would like to Pelvic Floor Foundation for giving us this opportunity to, share this information. I just would like to, use a couple of more minutes to also introduce our company, because we are, somehow kind of new to gynecologists. And I believe that this platform is a good platform for us to introduce ourselves and briefly talk about our vision in obesity area. I promise that it is not going to take time, but just to introduce myself, of course, I am Dr. Emin. I am head of medical affairs in South Africa. I am coming from Turkey, and you talk about the bariatric surgery, the patient who had the bariatric surgery in Turkey. Yes, it is very common, but prevalence of obesity also in Turkey is very common. But we are so proud of, as a Novo Nordisk, that we are providing some other options to our patients to not, only bariatric surgery, but via pharmacotherapy, they might find some solutions. And regarding the question of the patient support program, I think that the patient support program is available for all patients who is prescribed for Saxenda. And if our esteemed doctors needs more information, I think that they can find our sales rep to give further information, or maybe they can write their name actually on the chat box that, after the meeting, we can reach out to them if they need more and further information. But if you look at the Novo Nordisk at a glance, that I'm proud of, I'm glad to say that we are celebrating our 100th year of the anniversary of our company this year. And it's been 100 years. And for a long time, Novo Nordisk was new as a diabetes company. But recently, we expand to other different therapy areas, such as the rare disease. And for the last couple of years, we expand to obesity. But now we expanding other therapy area to bring more innovative treatment to improve patients of life, right? So in our mission in obesity, which is, I mean, I think that is so much important. It is not only driving change by developing a leading portfolio of superior treatment solution. We are working hard to bring the superior treatment solution, and liraglutide 3 milligram is one of the first pharmacotherapy in obesity that we brought to our patients. We continue to develop our pipeline to bring the superior treatment. But also, in addition to that, I think that it is important to highlight driving change in how the world sees people with obesity and make obesity a healthcare priority. That is so crucial when it comes to obesity treatment. The reason behind it that people living with obesity, they would like to lose weight. But the issue that because they don't think that obesity is a chronic disease, they tend to do it by themselves. They are avoiding to talk with an HCP. They think that it is their fault, actually. It is their responsibility. If you think that it is your responsibility, why you are going to talk a doctor? Why you are going to talk a healthcare professional? Usually they go to internet, they try to find some diet and they try to handle it by themselves. And if you look at from the other side, again, they go to a doctor with the complication of obesity, not directly with obesity. They go to doctor with hypertension, diabetes, mellitus or coronary artery disease, or PCOS or fertility, but they don't go or they don't get the treatment of obesity, which is the main reason of this complication. So that's why I think that now I'm going to finish my slide or presentation with this slide. The reason behind it, last week, 4th of March was the World Obesity Day. And the theme of the World Obesity Day was the let's talk about obesity. I think that message is so crucial because these patients, they are just seeking a treatment. They think that it is their responsibility. And as a Novo Nordisk, our theme is together we are driving the change. And I would like to thank each one of you for joining to this session and our platform, organizer, and the Dr. Carter again, and wish you all a great evening.
Thanks so much. Yes, thanks so much again for your support and for your passion for this area of medicine as well. And we appreciate everybody else for joining tonight. Yes, Pete.
Steve, I just want to remind you that we're talking OAB next week. We're talking, at least Steve is, his presentation is Recent Advances in OAB by Professor Stephen Jeffrey, and that's sponsored by Stella. So ladies and gentlemen, thank you very much. Ash, a huge big thank you. And of course, as always, a thank you for Steve here for the use of your minibar, Steve. Thank you.
Pleasure. And I'll just quickly put this, I'm sorry, it's very cluttered, this slide, but you can see the program for the
essential
for the workshop on the side. There's some live surgery. You can see we're showing some TVTs, we're showing some Bulkamid, talking about some complications. And don't forget about that workshop again. Thanks so much. That's in 2 weeks' time.
That's the 25th of March, the workshop, Steve.
Yes. Great. Thanks.
Great home. Okay, thanks, Steve.
Thanks so much to anyone. Thanks to Ash as well.
Safe home. Thanks very much.
And thanks. Bye-bye.
Bye-bye.
Bye.